Good afternoon. My name is Connie Newman. I'm an endocrinologist, and I'm very pleased to have the opportunity to speak to you today about hypercholesterolemia and its relationship to cardiovascular disease. I started out my career in endocrinology working on pituitary tumors, and about 18 years ago I had the opportunity to change direction, and I began to work on the statins and on large cardiovascular outcomes trials of statins. So the two topics that I would like to address today are statins as effective in women as in men. I would also like to give you an update on the newest class of medications to treat high cholesterol, the PCSK9 inhibitors. I have no conflicts of interest, nothing to disclose. Whoops, I went back. Am I going the wrong, is it this one? Okay, so first I want to start with the topic, are statins as effective in women as in men? Do I have to wait? Very slow. Okay, so we all know that statins not only reduce LDL cholesterol, but they also have a significant impact on cardiovascular disease, reducing myocardial infarction and stroke, both fatal and non-fatal MI and stroke, and also reducing vascular mortality. And in the United States alone, there are about 25 million adults who take statins, and there are many more who probably should be. But there have been several myths about statins in women. One of them is that statins don't work as well in women as in men, that statins do not reduce cardiovascular disease or cardiovascular death in women, that they cause more side effects in women than men, and they shouldn't be used in women for primary prevention of cardiovascular disease. Going back. No? Sorry, I'm finally back. So what I'm going to talk to you today in brief is about a meta-analysis done by the Cholesterol Treatment Trialist Collaboration. This is a large group of trialists. I'm a member of the collaboration. We've got 100, 150 men and women who have done large outcomes trials of statins. In these trials, there are many patients ranging from 2,000 patients to 25,000 patients with treatment durations of 3 years to 5 or 6 years. And in this meta-analysis, we looked at 174,000 participants in 27 trials of statins. 21 trials were compared statins to control, placebo or usual care, and the remaining 5 trials compared more intensive statin therapy to less intensive statin therapy. And here I'm showing you the baseline characteristics of the patients. There were about 46,000 or 47,000 women in these studies, 120,000 men. The mean age of the women was 65 years, the men 62 years. There were similar numbers who were smokers. There was more hypertension in the women, 60%. Blood pressures were roughly equivalent, 140/80. Fewer women, about 47% compared to men, had a history of vascular disease, and 24% of the women had diabetes mellitus compared to 18% of the men. So I'm going to start with giving you an overview of the results, and then I'll show you some of the data. So women were generally at lower cardiovascular disease risk in these trials. Statins had similar effects on 1-year lipid levels in women and men. And the reduction in major vascular events per millimole per liter reduction in LDL cholesterol was about 20%, and a millimole per liter translates to about 39 or 40 milligrams per deciliter. And the reduction was about 20% and was similar in women and men, and including those patients who were at lower risk. And what do I mean by major vascular events? Well, I'm talking about fatal or non-fatal MI or stroke and coronary revascularization procedures. And I also wanted to add, I'm not sure if I mentioned this, that in these meta-analysis, we don't look at study-level data. We look at individual participant data. We have the data on each patient, and we pool it, and this gives us a more robust findings. So I'm going to try to use the pointer and try to walk you through this. How many of you have seen these types of graphs before? This is known as a whisker plot, and what we're looking at here are the events and the percent per year in the statin group or the more intensive group and the control group. And men are on top, and you can see that, and this is you can see in the placebo group who were not treated with a statin, 4.4% had a major vascular event. And in women, there was a lower rate of major vascular events, only 3%. And when you look overall at the risk reduction, if the risk reduction falls on the left side of this line, then that means that the statin or the more intensive statin therapy was beneficial. And what we see here is that the risk reduction in major vascular events was similar in men as in women, and the overall risk reduction was about 21% with a hazard ratio of 0.79. This slide shows data divided by looking at people who had prior vascular disease and those who did not. So if we look at here, oops, go back, trying to point, at the people who had a history of vascular disease, here are the men and the women, and there were similar risk reductions in people who had a history of vascular disease. However, in people who did not have a history or known history of vascular disease, you can see there was a slight difference. There was slightly less reduction in risk in the women compared to the men. But not all of these patients were healthy. Some of these patients had chronic kidney disease or diabetes. So the number needed to treat was calculated, and it was just found that for people with low 5-year risk of less than 10%, the absolute numbers of vascular events avoided per 1,000 participants who had a millimole per liter, a reduction in LDL cholesterol, was 9 in women and 12 in men. Now I'd like to turn to talk about the latest advance in cholesterol management, the PCSK9 inhibitors. So what does PCSK9 stand for? It's protein convertase subtilisin kexin type 9. This is a protein synthesized in the liver which enters the circulation, binds to the LDL receptors, and targets them for degradation. And this is a schematic showing the PCSK9 molecule in purple binding to the LDL receptor on the hepatocyte, bringing the LDL receptor to the lysosome for degradation, and the PCSK9 molecule is secreted from the cell. So when this happens, you have fewer LDL receptors, and you would have an increase in LDL cholesterol. But if you could block PCSK9, you would have a decrease in LDL cholesterol. So it's been known for several years that mutations in the PCSK9 gene are found, that a gain in function mutation causes high levels of cholesterol, but loss in function mutations cause low levels of cholesterol and are associated with increased incidence of coronary heart disease. In African Americans, the prevalence of these loss of function mutations is about 2.5%, associated with a 40% reduction in LDL, and in whites the prevalence is about 3.2%, associated with about a 20% reduction in LDL cholesterol. And these graphs show the LDL levels in a normal person, where the average would be 113 milligrams per deciliter. And here we see the LDL levels in African American patients who have loss of function mutations in PCSK9. You can see a shift in the LDL levels to much lower levels, the mean being 100 milligrams per deciliter. And also when people looked at these patients over 15 years of follow-up, people with these loss of function mutations had 88% fewer coronary heart disease events. So this meant that PCSK9 might be a really good therapeutic target for developing a new drug to lower cholesterol. Trying to advance. Okay, so the monoclonal antibodies to PCSK9 were the first medications developed. They reduce LDL cholesterol by about 50 to 60% as monotherapy, or in combination with a statin or ezetimibe, which is a cholesterol absorption inhibitor, and 2 monoclonal antibodies were approved in the summer of 2015. So this chart shows the alirocumab and evolocumab, which are the 2 approved medications. It shows the doses and the mean percent LDL reduction. And alirocumab is given as 150 milligrams subcutaneously every 2 weeks, but the other drug, evolocumab, can be given as 140 milligrams every 2 weeks or in a higher dose of 420 milligrams every month. and they produce reductions in LDL ranging from about 58% to 64%. However, only evolocumab was studied in patients with homozygous familial hypercholesterolemia, shown on the bottom of the slide. This is a very rare disorder in which people really have very little LDL receptor activity, and surprisingly, there was a 22% reduction in LDL in these patients with homozygous FH, and these are people who develop coronary artery disease when they're in their adolescence or in young adulthood, because they always have these high levels of cholesterol bathing their coronary arteries. Oops, that's that. So I wanted to show you just one trial of PCSK9 inhibitor. This is alirocumab. Oops, it's not there. Lost it. So this is the Odyssey long-term study done with alirocumab, and patients were already on statins, and you can see that the ones randomized to placebo up here had a stable level of LDL, about 119 milligrams per deciliter at the midpoint of the trial, 123 at the end of the trial. But those who were randomized to the PCSK9 inhibitor alirocumab had a big drop in cholesterol. They were of 61% on top of the reduction due to the statin, and their levels at 24 weeks were 48 milligrams per deciliter, which is really quite good, and 53 at 1 year. So alirocumab and evolocumab were approved by the FDA for the following indications: to be used as adjunct to diet and maximally tolerated statin therapy in patients who require additional LDL cholesterol lowering, and these would be patients, adults with familial hypercholesterolemia, heterozygous, and adults with clinical cardiovascular disease. Evolocumab did studies in homozygous FH patients, so they also got an indication for use in addition to diet and statin therapy in patients with homozygous familial hypercholesterolemia. Of course, when I talk about efficacy, it's always important to talk about safety. So we don't have that much safety data yet because the long-term cardiovascular outcomes trials have not completed, but what we know from 1 to 1.5 years of follow-up with these drugs is that there are some serious hypersensitivity reactions, but these are rare. That injection site reactions occur in about 4 to 5% of people. There was myalgia in some of the patients in some of the trials, but not all. But what was interesting is that there were neurocognitive events in about 1% of patients, which was about 0.6% greater than placebo. And these events included amnesia, memory impairment, confusion, cognitive attention disorders, disturbances in thinking and perception, and this does not mean that these drugs cause these neurocognitive events. This has to be further studied. Let's see. Trying to get to it. Okay, so there are ongoing outcomes trials I mentioned before. These should be done in a year or two. The Fourier Trial is being done in evolocumab, and this is in patients with very high risk of cardiovascular disease, and the Odyssey Outcomes Trial being done with alirocumab in patients who have had acute coronary syndrome, and we're eagerly looking forward to the data from these studies. But I wanted to share with you one of the problems with these medications. They're great at lowering LDL, and they're a big advance. However, look at the cost. You can see on this slide that if you took a atorvastatin 80 milligrams per year, this is a great drug, lowers LDL by about 50 to 60%. The cost could be $156 per year. Some of the other drugs that are branded, such as, this is ezetimibe, it costs about $3,000 a year, colesevelam, $6,000. But when we get to the PCSK9 inhibitors, their price right now is around $13,000 a year. And this cost will be prohibitive to many patients. So in summary, I want to say that I've shown you some data showing that statins are as effective in reducing atherosclerotic cardiovascular disease risk in women as in men who have the same level of atherosclerotic CVD risk, that monoclonal antibodies to PCSK9 as monotherapy or when added to statins inhibit LDL receptor degradation and reduce LDL cholesterol levels by 55 to 60%, that alirocumab and evolocumab are indicated in addition to diet and maximally tolerated statin therapy to reduce LDL cholesterol in patients with cardiovascular disease or heterozygous FH who require more LDL reduction, and that evolocumab is also approved for the rare patients with homozygous familial hypercholesterolemia. And that safety concerns thus far are injection site reactions and perhaps changes in neurocognitive function, and the latter is being evaluated. Cardiovascular outcomes trials, which will tell us a lot more about the safety of these drugs, are ongoing. And I wanted to also add that pharmacy utilization management programs are still defining the criteria that determine which patients should be dispensed PCSK9 inhibitors because of their cost, $13,000 a year, and that the high cost of this new therapy may be prohibitive for some patients. So I'd like to end here, and I would like to acknowledge my collaborators in the cholesterol treatment trialist collaboration. I've worked with them for many years. I'd also like to acknowledge the patients who participated in these trials, over 170,000 patients, as well as Dr. Jennifer Robinson and Dr. Jonathan Tober. So thank you very much for listening.